Once the diagnosis is confirmed, we move to treatment. But before we even think about anesthesia, we have to talk about stabilization. You cannot perform successful surgery on a patient in shock. We need to aggressively rehydrate with IV fluids, correct those electrolyte imbalances, and get pain management, usually opioids, on board immediately. We also start antiemetics like meropitant or ondansetron to stop the fluid loss. Here is a critical do not do rule. Never give prokinetics, like metoclopramide, to an obstructed patient. If there is a blockage, giving a drug that forces the gut to contract is like pushing a car into a brick wall. You will cause a rupture. Now, how do we get the object out? If we catch it early and it's still in the esophagus or stomach, we might get lucky with endoscopy. This is the ideal scenario. Grabbing the object with a scope means no incision and a very fast recovery. However, most cases require surgical intervention. Gastrotomy. If the object is in the stomach, we cut into the stomach wall. This is a robust, forgiving organ with a great blood supply, so this is a relatively low-risk procedure. Enterotomy. If the object has moved into the intestines, we perform an enterotomy. We make a longitudinal incision downstream from the obstruction, in healthy tissue, to extract the item. Resection and anastomosis, or R and A. This is the heavy lifting. If the intestine is necrotic, purple, or perforated, we cannot leave it. We have to remove that dead segment and sew the healthy ends back together. This carries a higher risk of dehiscence, or leaking, but is life-saving. Finally, a special rule for linear foreign bodies. Never pull the string. If you pull, you act as the saw. Instead, we surgically release the anchor point, under the tongue or at the pylorus, and then carefully remove the string, often requiring multiple enterotomies to feed it out gently without slicing the tissue.